So now we want to have some interactive panel discussion so that everybody is awake and widely aware of what is happening in the hall, so that we can learn something and take away some of the important points from these very important and very carefully selected abstracts. We had to do a lot of homework to select these abstracts. Hopefully, these will make way to the practice in most of. So when we see so much of data, what happens that we are most of the time confused. It adds to the confusion, but most of the time we are unable to make out the actual thing which is changing the practice and what is to be extracted from the same. So that is the most important why. That is why after this presentation of all the abstracts, we require some discussion so that we can take that forward. So I will take this abstract first, impact of relugolix versus luprolide on quality of life in men with advanced prostate cancer, phase 3 hero trial. So when we see this data, the eligibility criteria, I will first ask from our medical oncologists. Dr. Samir, you can take it first. Samir boss, do you think the end point of this study is correct and is sufficient for practice changing?
So sustained castration rate, that is what we want for from our any type of ADT.
Yes.
If we give either it can be surgical or medical castration. So end point is correct. That castration level should be equal in both the groups. So the primary means the study was to see whether the quality of life is better with relugolix or not. So that is a good thing. Is the efficacy is same? Then we are trying to see which treatment is having less toxicity. So if other modality having same efficacy with less toxicity, it can be practiced.
It can be practicing. So it's about the efficacy of the treatment, at the same time the toxicity of the treatment. But the most important point which we see for our patient seems to be compliance. So that is also important. Amit, you would like to make a comment on the same?
Yeah, so that's most important. So luprolide taking 3 monthly or even 6 monthly has a better compliance as compared to relugolix, a patient which have to take daily. So you are adding something to the patient daily. So unless it is found to be more efficacious than the initially 3 monthly or 6 monthly treatment, it will not be used in regular practice. So we have to find something different with this drug, which is of use.
So it seems that let's have a comment.
Yeah. So it is interesting to see this slide when you see the primary endpoint of sustained castration rate is 88.8% in luprolide. That means, are we doing something wrong for last so many years? We should have been doing bilateral orchidectomy because 12% do not, according to this, do not reach castration, which means I have to go back and think, where is the data being lost? It's anybody's guess. If I go back after this, I will stop writing luprolide and I'll go back and check. But I'm sure most of us sitting here have been using it for 2 decades at least. And we have been doing testosterone every time and seeing the response. I think there's something wrong with this data. So whatever is the conclusion has to be taken with a pinch of salt.
Yeah, I completely agree. But that is what we see in our practice as well. We are conducting close to 6 trials in prostate cancers presently at TMH Varanasi. We tend to see that serum testosterone level might not be below 20 in all the patients. It is most of the time below 50, most of the patients, but below 20 is not of the most of the time able to be achieved. I would like to take comment again from our team. Dr. Rahul. Yeah. Okay. So see, it seems that the compliance will be a very important point for our patients. However, it can be what I think it can be utilized in selected patients who are very worried for taking injections 3 monthly or 6 monthly basis, and they ask that if it can be substituted by any other treatment. So this is an option. So additional option available to us, but might not be used for every patient, which we are utilizing in the practice. Even we see patients defaulting for 3 monthly luprolide. So there is always a compliance issue which we need to take care of. I think
even these are all old patients, must be taking multiple tablets for diabetes, hypertension, and other problems. So missing a tablet is a very common issue with this.
Yeah. So I would like to, is Dr. Piyush available? Yeah, Dr. Piyush, sir, I would like to take your comment on this particular slide. This is taken from your slides only. So I would like to take your comment on this specific various domains of the ERTC quality of life. It seemed to be important to me, so I thought I will take your comment.
So basically, it is showing that there is not much of a difference over here in terms of the hormone-related symptoms, the bladder-related symptoms. There was no data, not much of a data because of the low patient number in the sexual functioning, which we would have wanted to see after testosterone, especially at week 49, because at week 49, there is a testosterone surge happening with the withdrawal of relugolix. So that data could not be there because of the small numbers.
No.
So otherwise, there was not much of a difference between most of the parameters.
Okay. Okay. Interesting point. Yes. So it seems that we are somewhat asking about whether intermittent ADT is a possibility or not, because this ADT can be managed and self-managed by the patient himself or himself. So that's a problem. So if patient is having some issues, the patient might try to stop himself, and that might lead to some different outcomes. And this trial was powered for just sustained castration rate. Whether it was leading to some differences in the outcomes, we don't know. So I think your question remains unanswered. We don't have any direct answer to the same. Anybody would like to add anything?
So for loss of testosterone to cause loss of libido, it is not that you do orchidectomy today and tomorrow the libido will be lost. Testosterone is a maintenance fluid for erectile function. So as long as that maintenance fluid is there, it is maintained.
Yeah.
It will eventually go, but it will be a variable period between, say, maybe 2 months to 6 months when it is completely gone. So it is not switch on, switch off. So I don't think, and this is a 43-week trial, I think it's a 43-week. So it's little small trial. I do not know, but the basis is not switch on, switch off.
So the message which we are getting from the experts is that if the patient stops for a few days, we don't expect them to see differences in the sexual activity, libido, and other things. That is the message which we are getting. But we need to get some more data of what is happening actually. So let's come to the next abstract. So androgen receptor inhibitors or taxanes for patient with MCRPC. So this is a ProBio study, which we know that is important, and how to select the patient. That remains a problem in our settings. Anybody would like to comment any biomarker they try to do in CRPC patient other than HRR in their real practice? Anybody would like to do any mutations in the real practice? RB. Okay. Yes.
Yeah. It's like that is what I find. Other than that, only
HRR is the established one. Dr. Amit, you were talking we had a discussion and you were discussing about aggressive variant prostate cancer. Any comment on AVPC? AVPC is very commonly missed, and we don't we see MRCPC as a single group, but it is heterogeneous. We know that. But till now, we are not practicing and managing differently till now. So any comment on So here I would like to give a real world example of my practice, means my hospital's entire DMG practice. there's a patient who was known to Dr. Varun, who is already here in the panel. He's a very great nuclear medicine expert. He was with us, and then now he has moved to Sangrur. The patient had received ADT for a long time. Then we started the patient on abiraterone plus docetaxel. The patient had progressed within 3 months. Now what to do? We did do some scans. Dr. Varun would like to highlight that patient.
So in this case, when we did our PSMA scan to stage the patients, we saw that the patient had disproportionate large number of visceral metastasis compared to skeletal mets. And these visceral mets were not showing PSMA uptake. So these are situations when doing an FDG PET CT may help you identify AVPC cases. So when we did FDG PET CT in this particular case, we saw that all those lesions were metabolically active and not showing PSMA expression.
Yeah. So when we see such case, small cell cancer pops up in our mind. But again, we biopsied this patient 2 times, one from the prostate again, and second from the liver, where the disease. But again, it was adenocarcinoma only, no small cell cancer. Then we did NGS on both the panels, both the tissues, and we got P53 and P10 mutations in both the sides. So in fact, P10 was having very high VAF in the liver. So P10 VAF was going towards 60 to 70%. So that highlighted this is an aggressive variant prostate cancer with disproportionate high visceral metastasis. So all patients with visceral metastasis, they might not be small cell cancer, though we always should do biopsy to rule out a small cell cancer. We need to do particular molecular markers. Now, P53, RB, these we are already doing in multiple other cancer. P10 IC is also very available easily in-house in most of the centers. So if out of the 3, any 2 are positive, that means are lost. It means that it is aggressive variant, molecular aggressive variant prostate cancer. And there is already a data which shows that addition of platinum to this, such patients might benefit the patient. So the patient was started on carboxy plus carbo. The patient received 3 cycles. There was a very good response. We did both the scans, FDG plus PSMA. The patient had significant reduction in both the sites, both in prostate and liver. We did 6-month scan. Carboxy carbo was continued. Then after 6 cycles, we stopped carbo, continued for 3 more cycles of carboxy. The patient is doing well from last 15 months. So that is the way patient had progression upfront on abiraterone plus docetaxel, but now has 15 months of progression-free survival. So here it comes the way of identifying the molecular driver which is present. The patient was negative for other mutations. There was no BRCA, no other HRR mutation. So here we tend to do only HRR and forget other things which are already available and are much cheaper also. So these 3 IHC I recommend doing in all the patients so that we can identify the patients who are molecular aggressive variant prostate cancer. So that is the message I wanted to give. And this study tried to give some of the similar message that this is required. That direction, correct. So it might not be manifested in the form of small cell transformation clear cut, but it might be the transformation phase. So I completely agree. So this is another study, biweekly versus tri-weekly carboxytaxel. This was presented by Dr. Sunil. Dr. Sunil, I would like to get your comment on this study. You had presented this data just a few minutes back. So please, requesting to give your final comments rapidly. Please come to the mic. I will not spare anyone so that everybody is involved in the discussion. I would not let anybody sleep and please.
Commenting on the study particularly focus on the elderly patients more than age more than 65 years when they are unsuitable or their tolerance may be of questionable. So in this study, they assess when the carboxytaxel was given at lower doses, 16 milligram per meter square, along with GCSF support, the rate of neutropenia, febrile neutropenia, and neutropenic complications was significantly low compared to the standard regimen, that is 3-weekly schedule. It was almost 62% in the 3-weekly regimen compared to less than 5% in 2-weekly regimen. So this suggests that we can use cabazitaxel in a 2-weekly schedule.
2-weekly
And
schedule
lower
is
doses.
feasible. Any comment from the panel who are utilizing cabazitaxel routinely? Comments? Yes, please.
Yeah, I think the utility of this trial is very practical in our clinical practice because as we move ahead of docetaxel, obviously there is a concern while thinking about cabazitaxel about the toxicities, and we all are concerned. Though we have data to support 20 mg per meter square, again, the risk of febrile neutropenia or neutropenia is not completely eliminated. And what this trial has shown is almost none of the patients had a febrile neutropenia, and only 5% neutropenia. So I think that's very practical.
Yes.
Another, I want to know what about the peripheral neuropathy status, because apart from febrile neutropenia, neuropathy is also an issue because patient has already received docetaxel. Then if there's any reduction in or symptomatic relief by 16 mg compared to 25 mg, this you have to see.
Yeah. So neuropathy is very important aspect which should not be missed. In fact, we are conducting 2 studies for supportive care in cancer with neuropathy. One of the drug is palmitol ethanolamide, which we think is going to be an important game changer. That is already been tried in diabetic neuropathy, and we are trying to incorporate the same in patients with neuropathy in breast cancers and prostate cancers on docetaxel and cabazitaxel. So I think that's a very important aspect which we should always take care in the mind. As a medical oncologist, our focus is most of the time on the getting a PFS, OS, but it is important to incorporate the quality of life parameters and provide good symptomatic control as well. So I think this is the message to the young residents, if any are available, so that we can understand it is not just about increasing life, it is about increasing quality of life for the longest possible duration. So here comes one of the most important studies, BRCA-away. BRCA-away trial was presented by our dear colleague, Dr. Pooja, who has now moved to Delhi. I will request first comments from our beloved pathologist, sir, Dr. Santosh Menon, sir, for HRR. So, sir, you have a talk also scheduled today. So I will write just a very rapid comment on HRR mutations and their importance. And what do you think is the prevalence in India and what should be done to incorporate it in the real practice?
I think there are some points which will be there in the presentation, but in general, Akhil, the inhibition is to do HRR in all patients. That's the money factor comes into play. We are not doing in all patients. I think we interact during a molecular tumor board, but in the patients in which you do, BRCA2 is definitely more than BRCA1. That's a well-known fact, and even in India, we are finding that. Obviously, you have drugs for that. The point is when you do the complete HRD, you might find other mutations like CHEK2 and PALB and all that, which are also targetable in these settings. So that's the importance in the metastatic prostate cancer. Now the guidelines, most of the guidelines say that you need to do the HRD genes, including the MMR also, which are the DNA repair pathway genes actually.
Thank you, sir. Thank you, sir. So I was having a discussion about HRD versus HRR. We have heard lecture of Senthil sir multiple times about HRD in ovarian cancers. Sir, I would like to get your comment here. That HRR is established for prostate cancer. There is no clear-cut data for HRD. Do you think why it is so in ovary HRD has picked up? Why in prostate cancer HRD is not being discussed throughout?
So I want to edit your statement a little bit when you say that HRR is established in prostate cancer. I think Santosh will definitely enlighten us better in the afternoon, but not all HRR mutations are the same. I think this is one very important thing that we need to keep in mind. Because when you show the Talapro study, it has combined all the HRR mutations into one group and then shown that the PFS for that group is better when you use the PARP inhibitor compared to when you don't use the PARP inhibitor. But we all will know from multiple studies that we have seen so far that this whole thing is driven by 2 or 3 mutations of the 16 or 11 mutations that many of these studies have actually done. So it will generally be BRCA2, which is the most important. BRCA1 is far behind BRCA2 in terms of sensitivity to PARP inhibitors. And then there's PALB2, there's CHEK2, then there's BRIP, RAD51C. And then there was a FDA-driven meta-analysis that was published very recently in the JCO, which also looked at CDK12. So these are some mutations where there seems to be sensitivity. So if you look at the whole bunch, the majority are not sensitive. And the classic one is ATM. You know, time and again, they will show ATM along with BRCA1 and 2 and then say that ATM is also sensitive. Now there's clear data that ATM is not sensitive to PARP inhibitors. So I think we need to be very choosy when you're using a PARP inhibitor in patients who have a HRR mutation. Some respond well, most don't respond well. So you should take Santosh's help whenever you decide to use a PARP inhibitor versus not. I think that's a very important lesson that we have to learn, because all these studies, when they show you the data, they will combine all the HRR together. You have to take the BRCA out and then show us what the data is to really convince us that it works in all HRR mutations. That's number one. The second question that you asked is regarding HRD. I'm also very, very surprised that we don't have HRD data in prostate cancer. I tried asking some experts about why they have not looked at it. Nobody has been able to give me a convincing answer as to why HRD has not been consistently used, because for me, it looks like a better indicator of PARP sensitivity rather than the HRR mutation. And we know from ovarian cancer data that HRR mutations, all of them are not the same, and then they don't respond well to the PARP inhibitor. While when you do HRD, you clearly show that the sensitivity of PARP inhibitors is much higher. So I really don't have a good answer to question number 2, but for question number 1, that's what it is. BRCA is simply unbelievable. For me, the data is very unbelievable. It's a very small study. But if you look at HRR mutation and the PFS to abiraterone, the PFS to abiraterone is double of the PFS to olaparib. The PFS to the combination is double of abiraterone. Something that is very difficult for me to really believe. The question that I'm asking myself is, where will I apply this in today's practice? Because today, wherever possible, you will use a triplet. You know, when they progress after a triplet, you already have exposed them to an ARPI or ARSI, whatever you want to call them as. And these are all studies that have been done in patients who've been not exposed to an ARSI in the first line setting. They are all ARSI naive when they went to the CRPC setting. Well, our patients today don't belong to that category. I don't have a patient who belongs to that category at all, because everybody gets a doublet, if not a triplet to begin with. So the question that I'm asking here after seeing this data is, should I keep the ARSI and add the PARP inhibitor if I find a HRR mutation that is sensitive to a PARP inhibitor? Because if it's doubling, there's something that's happening, which we clearly don't know at this point in time, because that's a hypothesis behind all of these studies, that when you combine the two, you get a better outcome compared to when you use either of them alone. But the better outcome with abiraterone for me is surprising compared to what you get with the PARP inhibitor. So I'm thinking, if somebody has HR mutation, then should we add or stop the ARPI and just use the PARP inhibitor? I'm kind of getting convinced that you should add rather than completely stop. So that's about BRCA way. Sorry for being, so long, but I think it's important.
Thank you. That was a very important comment. In fact, that is the thing which we are discussing as well. And we are trying to design a study for the same as well, that based on the HRR mutation presence or not, we will decide the sequence of the treatment. For example, patient having HRR mutation, docetaxel alone, along with ADT in the first line, then keep androgen ARPIs for the second line, along with the utilization of olaparib. So that is one of the strategies that seems to be exciting, but we don't know whether.
Can I make one comment? Sorry again to take some time of yours. There's a nice study called as the Triton 3 study. I'm sure you would have come across that, where if you have, so these patients were randomized either to docetaxel or to, rucaparib in the Triton 3 study. Now, if you look at patients, so some of them had docetaxel, some of them had an ARPI. That was the physician's choice. You could choose either of these. And the test arm here was rucaparib. So in presence with BRCA mutation, the PFS for rucaparib was nearly double of that you get with docetaxel. It was 8 months compared to 14 months. So for patients who have a BRCA mutation, not a HRR mutation, if you have a BRCA mutation, and predominantly that's BRCA2, your first line in CRPC should actually be a PARP inhibitor. And then after that, you get a docetaxel, and then, one after the other. So that sequence is now clear when it comes to CRPC. Agree.
For HSPC setting, I think,
For me, the greater question is, should you add a platinum?
So for HSPC, we will give dosi and will avoid utilizing abiraterone in such patients, and we can utilize the combination in CRPC setting. That is what I was trying to emphasize. Yeah, completely agree. So moving further ahead, another abstract, talazoparib plus enzalutamide, that was presented this year ASCO as well in detail. And there is also further data that This is also one of the other combination option apart from olaparib plus abiraterone, but talazoparib is not yet available to us. Now, I would like to just discuss about the toxicities of PARP inhibitor in brief. I would like to highlight why we are getting so much of myelosuppression in the present PARP inhibitors and what can be done to improve the toxicities and increase the efficacy. Anybody would like to comment? Anybody from the audience? I think we had some discussion. Pooja would like to comment.
The most important point I want to highlight that giving even in the ovarian setting also it is very difficult to manage the PARP inhibitors toxicity, because in rucaparib, like barely we used to achieve a full dose of rucaparib 600 BD. We usually start with the lower doses as well. Even for the olaparib also, we used to see a dose interruption and the most common toxicity with anemia and the fatigueness. So there the principle apply. Whenever we are starting a PARP inhibitors or olaparib, we should let the marrow recover first and then we should start the PARP inhibitors. And this duration can vary from 4 weeks to 6 weeks after stoppage of the treatment. So, and before starting the PARP inhibitors, we should evaluate the other nutritional deficiency causes like vitamin B12 and the folic acid and other causes of the anemia or chronic disease before starting these PARP inhibitors, so that we can manage the anemia and the fatigue per se part very throughout the treatment with very proper supportive care. And as we all know that dose reduction and other things are also, if it is a grade 1, we can continue with the same doses. With the grade 2, we can interrupt the treatment. But whenever there is a recurrent disease, we should not forget about the MDS, because if any pancytopenia and the bicytopenia are occurring 3 months after starting the PARP inhibitors, we should always consider MDS as the first priority and we should evaluate the bone marrow examination.
Thank you. Thank you, Pooja. Another point which I wanted to highlight is about PARP1 and PARP2 inhibition. PARP2 inhibition is being caused by all the drugs, and PARP2 is mainly responsible for the myelosuppression, while PARP1 is the main action for getting the benefit from the PARP inhibitors. So we need more selective PARP inhibitors. Talazoparib till now is the most selective PARP inhibitor. Now we are moving, I think we will get drug called saruparib in subsequent time. And we are going to have a trial of in prostate cancer itself. That trial is called EvoPAR, and that will be starting recruiting at TMH Varanasi shortly. So I think we need to get better drugs with lesser toxicity so that you can maintain the drug intensity, drug doses, so that there are no drug interruptions. That might lead to some improvement in the outcomes. We are not sure, but at least that will improve the quality of life of the patients. So that is the most important for us. So just coming to the last important discussion. Yeah. Yeah. So I think the same, the problem is that when you have a bulk being driven by one of the very effective mutations, other mutations are like me too. So they will also in the overall cohort, they will show the benefit. And if you are also seeing some of the forest plot, the number is so small that it is very difficult to comment on the same. So I don't think that that should be the message. You utilize the combination irrespective. Even FDA has approved only in selective cases. Yeah.
So I think just to make a point, the rationale of that explanation is lies in the molecular basis. I think what has been written in the literature is that there is a crosstalk between AR pathway and the PARP pathway. So whenever there is an AR inhibition, that leads to downstream inhibition of the PARP pathway as well. So, and also PARP is required for the AR transcription signaling. So in that way, there is some synergy using the PARP inhibitor and AR receptor pathway irrespective of the HRR. So that's what.
So that is one of the rationale and hypothesis point, but whether it is actually important and useful, it needs to be seen. But till now, our practice isn't so that we will utilize this combination in all the patients. Thank you. Something like that might be needed. Okay, thank you. Now we'd like to have two important abstracts very rapidly covered. Requesting Dr. Varun to highlight about the PSMA4 ENZA-P study in brief.
So PSMA4 was a phase 3 trial in which PSMA PET positive patients were taken for the study, where they were randomized into ARPI change arm, that when they were given first line of ARPI. They were either given ARPI change if they had progressed, or they were given lutetium PSMA as a monotherapy. In this particular study, crossover was allowed from ARPI change into lutetium PSMA if the patient had radiological progression. Here, one important point to see is that out of all the patients they had screened, around 85% was screening positive. So it tells that a lot of the general population would be eligible for lutetium PSMA therapy. Just like we use other biomarkers to see if a patient is eligible for any type of chemotherapy or immunotherapy. For PSMA, for lutetium PSMA therapy, we use PSMA PET-CT as a marker to see if it's going to have any theranostic benefit to these patients. So these patients had very high screening rate, and it was seen both in PSMA-4 study and the ENZA-P study as well. In that also, I think it had 82% screening positivity rate. Now comparing the results. So for PSMA-4 study, the radiological PFS was seen as 12 months for the lutetium PSMA arm and around 5.5 months for the ARPI change arm. So it had
request your comment, especially on the comparator arm, because that is the most important discussed point among the medical oncologists and other streams, that comparator arm was somewhat weaker. Your take on that?
Here the argument given by the team which had designed the study was that if a patient progresses on the first ARPI, the most common management done is to change the ARPI to a second line ARPI. Docetaxel, even if it is considered to be a more effective treatment, it's also a more toxic treatment compared to ARPI change. And lutetium PSMA, with the results of these studies, proved to be even less toxic than ARPI change. So its efficacy is better than ARPI change with even less toxicity. Therefore, they are saying that the PSMA is a promising alternative and an addition to the armamentarium of all the treatment options available in the initial phase of treatment of metastatic prostate cancer.
That studies have tried to, these two studies have led to the utilization of PSMA therapy in earlier setting, and that is what we have realized also. So do not keep the PSMA therapy also for the last line treatment, because we have seen that the effective treatments also given the last line will have less benefit. So try to utilize earlier. I will not say in the first line, but yes, it can be considered earlier, at least in the second or the third line. Don't keep it for the fifth and sixth line. Any comment?
Yeah, it's quite good to see that you are talking about the quality of life initially, and then morning we are talking about the artificial intelligence, the new term coming up. If we talk about these two studies, or apart from these two studies, the vision trial also, the lutetium in all three studies have the favorable side effect profile as compared to the other arm, be the ARPI change, with the docetaxel, or the in case of enzalutamide. So definitely in all form arm, the lutetium PSMA perform better, and it does not cause any loss of libido or disruption of any sexual dysfunction also. So lutetium PSMA is a definitely better drug as compared to that. And also the Dr. Varun had said, if we compare with the comparator arm in case of ARPI change as compared to why not the docetaxel. Docetaxel is not a simple drug. Most of the patients are not eligible. It is associated with lot of side effects. And the study has been conducted in the USA, where the standard practice is what patient is progressing on first ARPI, he usually change to the second rather than going directly to the docetaxel. So that's the scenario basically established by the Sutter et al. That we should compare with the second ARPI change as compared to the docetaxel. Yeah. And then in case of docetaxel alone, the vision trial has also established that if we add lutetium to the standard care of treatment, that is definitely going to improve the overall survival.
Just, I would like to make one comment. We are the students of Kumar Professor and Amit Joshi sir, and they have taught us from the day one. After abiraterone, don't directly jump to enzalutamide. After enzalutamide, don't jump to apalutamide and other drugs. So that is one of the things which we practice. We don't change from one ARPI to second ARPI in the real practice.
Yeah,
though this was
scenario happening in India,
I completely
in the US where studies conducted.
Yeah, I completely agree. But this is what we do, and that's the take home also. That this is not usually advised, but that is being done at most of the centers, because patients do not want to take injectable chemotherapy sometimes, and there are multiple other logistic constraints, and patient is also not fit enough for chemotherapy. So your point is well taken. Thank you.
Yeah.
Yeah. Yeah. So let me just come to a very important abstract, which is important for us, and we are conducting a study at our center under the PI of radiation oncology team. So that is a PROS-O study, oligometastatic prostate cancer study. So this is one of the abstract which I wanted to discuss with our radiation oncologist. Dr. Vinda, I would like to get your comment on this specific study, that this is the ARTO, this is the randomized phase 2 trial, which has now become available. It's a good and large study, actually.
So they focused on a not so good, not so bad biology patients, intermediate biology. And they've said that ablation should be offered to these patients. They focused on non-visceral metastatic lesions, bony and pelvic nodal. But there are other studies which have shown benefit of adding ablative radiation to visceral metastasis also. So in that biology, I think the aim should be curative, and before adding any second ADT or systemic therapy, ablative therapy to oligometastasis should be offered.
So I think, again, the message is that it is important to have a discussion on the multidisciplinary team when you encountered any oligometastatic patient. So again, the role of radiation oncologist should not be missed. So we had one question on contact to study, but we are skipping in the constraint of time. Thank you everyone for the encouraging participation in the discussion. Greetings from Team H Varanasi again. Thank you. Requesting Nandini ma'am to give the take-home messages from the medical oncology perspective.
So Akhil will give the take-home message for the MedOnc side, and Dr. Ram Alva will give it from the radiation oncology side, and then we break for lunch. So Akhil, 2 or 3 important messages for medical oncologists, and then I'll invite Dr. Ram Alva for the radiation oncology take-home.
I think we had very important discussions, and we got comments from much senior experts from us, from me, and Senthil sir highlighted very important pertinent points. What is the importance of selecting HR mutation, which mutation to be selected? Not all HR are the same. That is one important aspect. Utilizing the drug at the correct time is the message. Do test most of the patients if feasible, but utilize the drug correctly. This is the same for PSMA therapy. This is the same for incorporation of radiation. That is, incorporation of correct treatment at the correct time requires effort, multidisciplinary efforts. Initially, metastatic cancers were solely the responsibility of medical oncologists, though medical oncologists were not so much that they used to take the care. But now we have a lot of medical oncologists, and there is now a role of nuclear medicine, radiation oncology, even in metastatic prostate cancers, to be incorporated at the correct time. So that's the key message from my side. Requesting, yeah.
Good afternoon. I'm Dr. Ram Alva from Bangalore. Thank you, Ritika, and the organizing team for giving us an opportunity here. I'll just go through the radiation abstracts that were presented, the systemic as well as the SBID abstracts. So my slides, I'm not sure if it's, yeah. Okay. So just going through the initial lutetium trials that were presented, I'll not take a lot of time. So the first one was the PSMA-4 lutetium versus the RP change, and it has been discussed enough. So it was primarily used for taxane naive, and most of the lutetium trials initially was when taxane has been used previously, and it has definitely shown a radiological progression-free survival in these patients. And I just want to highlight the current role, which has been defined, is from the VISION trial for PSMA positive metastatic CRPC. And it has been treated mainly for the androgen receptor pathway inhibition as well as the taxane-based chemotherapy. After that, it has been used with a definite advantage in terms of overall survival and RPFS. And the dose around 200 millicurie for 6 settings. And common side effects are much manageable. So this was the current role for lutetium. The second one was the ENZA-P, where they've combined ENZA with the lutetium-177. And what is the take home? That addition to ENZA improved the PSA progression-free survival as well as the 50% and the 90% response rates. So again, an important component came in through with the lutetium. So what are we looking ahead for in terms of lutetium? There is a LUNA trial, which is combining SBRT with lutetium. The PSMA addition, which is a phase 2, where combining ADT, RP, and in the castrate-sensitive prostate cancer, and the Eclipse and Splash, where the standard of care is being compared against the lutetium. So these are the kind of trials we are looking forward to, and there are some advantageous things coming out with lutetium. Next is the SBRT role in metastatic. We try to get a foot in as much as possible in all such settings. So the first one is the ARTO trial. Madam just spoke about it. And what is the advantage? SBRT, in addition to the first line ARP treatment in metastatic CRPC, definitely shows a clinical advantage. Just a little word on the SBRT in oligometastatic prostate cancer. Because of the biology, because of the sensitive biomarker we have and the molecular imaging, definitely there is a role for local therapy. It's mostly used in castrate sensitive, but nowadays we are seeing more and more CRPC where SBRT can be used, and the number of lesions defined. So most of the trials right now are saying 6 and below, but there are studies which say up to 10 lesions, whether it is synchronous, metachronous, whether it's oligometastatic, progressive, or recurrent. So in de novo upfront oligometastatic, the HORAT trial, Stampede, as well as the PEACE-1, all of them gave a radiological PFS benefit. The awaited ones are the SWOG, Stampede-2, and the Platon, all of them combining SBRT in different mechanisms. We have a metachronous oligometastatic trial setup where Sabre Comet, the STOMP, and Oriole, which are phase 2 trials, NHS, all showing a PFS benefit. The awaited ones are the Sabre Comet 3 and the CORE trial. Though when it is these first two were all castrate sensitive prostate cancer. Now it's a castrate resistant. We have the ICE-PAC, where they combine apalutamide with the radiation, PFS benefit again. And the awaited ones are the FORCE and PILAR trials. And with systemic therapy, we have used extend therapy, all showing even some early OS benefit. The awaited ones are the DART, darolutamab, and SBRT, and Ravens, which is radium-223 and SBRT. Again, looking forward to these results. So as of now, SBRT is well examined in this setting, and it's showing excellent results, and definitely something that has to be considered even in the metastatic setting. The last one is the Medcare trial, where it is a single-arm study about progression-directed therapy. And in oligoprogressive metastatic CRPC, PDT postpones the need for next-line systemic therapy by almost 1.5 years without inducing any severe toxicity. So it's an important component because some of the medical oncologists here put across the point that continuing systemic therapy continuously is a difficult point in such patients. And this gives a rest from systemic therapy with the use of proper SBRT. So what are the trials that have been used? STOMP and Oriole, like I mentioned previously, phase 2 trials in castrate-sensitive prostate cancer. There was a PFS benefit. And they also found that those with high-risk mutations like ATM, BRCA, or TP53, these patients, they had a worse median progression-free survival, and therefore these can be used for prognosticating. We are looking forward to the PROBE study, SBRT with radium-223 in less than 6 bone mets. Oligopelvis, where SBRT is combined against surgery in those who have pelvic nodes. And the PCS9, which is SBRT with ENZA, and the PILAR study, which is a SBRT with apalutamide. So these are the studies looking forward to for PDT. Let's just last slide. So we have the different mechanisms that you can see on the slide, and we need to piece it together for metastatic prostate cancer too. Thank you.
Panelists.